Good evening for everyone. I would like to thank Dr. Vinood, my friend, for the invitation, and I'd like to thank the chairmen for having me to talk. I'm to speak about laparoscopic colorectal surgery. I think it's a topic we have went over a few times. This time I'm bringing it from a different approach, going back in history and a bit more to the future. And at the end, I have a small video. If time permits, we will view it. So facts, it's 25 years of hassle and discussion between surgeons. Should we do colorectal surgery laparoscopically or should we do it open? It went through different studies. It was a painful discussion all through to prove that at least laparoscopic colon surgery is equivalent or as good as open surgery. So the benefits, it's painless and it's less medications, proven by multiple trials, which we're going to go through. The LACI trial demonstrated an improved cancer-related survival for stage 3 patients. So this was the question which was discussed at multiple meetings, whether is there a cancer-related benefit in laparoscopic colorectal surgery or not. Port seedings was discussed, and it showed that there's no major differences. Facts from the Barcelona, whether the Coast or the Color and the Classic, they all showed that the port seeding and recurrence of disease at port due to pneumoperitoneum is not higher in most studies to the regular open surgery. There's fewer adhesion formation post-surgery, there's decreased risk of wound infection or herniation, and a decreased risk of infertility with a proper laparoscopic knowledge. Knowing that the scope would give you a higher magnification at vision of the fields. The database by the NSQIP was done, and it showed that between 2006 and 2007, the wound infection was equivalent. And other diseases with either with deep or superficial wound infection and with organ-sparing infection, it showed that the amount of infection present is way less in laparoscopic surgery than in open surgery. So queries, survival, which we have also discussed that the LACI trial had showed that there is a survival benefit and surgical outcome, which is beneficial in laparoscopic surgery over open in colon, not rectum, but colon. So over here, this is a paper which was published in 2010, if I'm not wrong, and it speaks about the laparoscopy for colon cancer, state of the art. It alluded that about the questions which should be asked in reality is why. So the first question was, why do we have thousands of patients who accept to have laparoscopic surgery for colon when there is no, at that given time, there was no proof of it being superior or equal? The second question was the oncological outcome. Was it a better outcome or not? And the third was the current technical approaches that are in use and what does the future hold for new advances. And this paper discussed this thoroughly, taking the 3 trials, the Coast and the Color and the Barcelona trial, which showed and the Classic, and it showed altogether 3,131 patients divided among the trials. For the pain, this showed that the outcome, and due to 7 randomized trials, the use of pain management was reduced by 30.7%. And the complaint of pain was brought down to around 12%. If we look at the different overall survival into different trials, it was not of much higher benefit. So it showed on the Coast of a 67.4% versus 76.4% versus 74.6%. And the Color, again, 73 versus 74. So the difference was not great in different studies, showing that the superiority of one over the other, let that be laparoscopic or let that be open surgery. Again, the operative percentage for open versus the laparoscopic in the coast, color, and classic, with the local recurrence and the wound recurrence was not different or significantly different in all trials. Conversion rates were divided. So the main discussion, which was always discussed in all the trials, that most of the cases which were done laparoscopically, or there was a high conversion rate at the beginning. Over here, we totally do not talk about the experience of the surgeon, which grew with time. So the reason of conversions were divided into these studies, showing that they had 21 conversion in percentage due to adhesions. And of course, this has decreased with time with the more advanced techniques and expertise of surgeons. And then the mobilization, able mobilization of the colon, again, was around 11% in the coast. It was not discussed in the color, nor was it discussed in the Barcelona. So in reality, the conversion rate at the beginning was high, and as the expertise of surgeons increased, the conversion rate went down. Laparoscopic resection for rectal cancer is another discussion, whether till today, we do not say that laparoscopic rectal cancer surgery is superior in laparoscopic than in open. For this study, it showed that there is some significant differences. I apologize for the very small writing for this one, but this took the classic, the Korean trial, the Color 2, and the illusion and the different trials where they showed there is no significant difference in laparoscopic and in open, whether in operative time with minor differences. The main differences which showed that the bleeding in laparoscopic was way less than what was in the open surgery, and the outcome and the TME and the lymph node harvesting was not less in the laparoscopic as compared to the open. So it was equivalent. We find 1 or 2 lymph node differences in one and the other, but they all have achieved the oncological requirement. So today, we have enhanced recovery programs which improve on our patients, decreases their in-hospital stay, increases on the mobilization and organ refunction, and the discussion of medial to lateral approach, or the non-touch technique, comparing the to open, knowing that most surgeons, when they do open colon surgery, they do from right to left, although in 1913 on rat or in mice-based studies, they showed that there is dissemination of cancer cells. This is lung, it's in a lung model, that there's dissemination of cancer cells if we do mobilize the tumor area prior to ligation of the vascular system. So in 1953, it was, by call, it was brought that it is advisable to ligate the vascular structure and the lymphatic structure prior to touching the malignancy area. And thereby in 1952, in Cleveland Clinic, in 1953 in Cleveland Clinic by Trunbull, he identified the utilization of the non-touch technique, which is done by the laparoscopic approach from medial to lateral. So medial, you first tackle the vessels, the lymphatic system, and then you go in to the colon surgery itself by resecting the colon. The difference between what we do laparoscopically today and the technique which was developed in 1953 was they would transect the colon prior to tackling the colon. So they would do the transection at the transverse colon and then continue the surgery. So minimal invasive today speaks about TAM and the accuracy of resection. They speak about the hand-assisted, which did not show any superiority, whether it's hand-assisted or open surgery, hand-assisted or laparoscopic surgery. The TAMIS and the TME, or the bottom-up surgery, it shows today with better expertise, a easier approach for bulky pelvis, bulky rectum in a small pelvis, or for obese patients. and robotic assisted in rectum is superior than the laparoscopic surgery due to the maneuverability of the arms of the robot and the ability of it to visualize a 3D image in the lower part of the rectum going towards the anal canal. So step approach, again, we just heard earlier about the checklist. The checklist in laparoscopic colon surgery we should be having in it the anatomy and the anatomical landmarks in either left or right or transverse colon, even rectum, with the nerve formation, proper strapping of the patient, knowing that the patient can go at very steep antitunnel bearing positions, and tucking of the arms for a better maneuverability of the surgeon around the patient as required, and ensuring IV access, intraoperative IV access for the patient. The positioning of the surgeon should be known earlier to surgery. Where is he going to stand, whether it's left, right, or total colectomy? So the positioning of the patient, the surgeon, and the instrumentation around the patient is important. Then the different variation of port insertion should be discussed and understood in the OR, the different sizes of ports which are to be used. And not to forget to use the wound protector, which you can see on the lower right and lower right of the screen. Landmarks, identification of the ureter and the gonadal vessels is very important, and this helps us to achieve a bloodless surgery. Proper identification of the nerves in the upper rectum, where you can spare them and keep a potent patient and a good urinary function. And knowing that the pelvis is a well, and I sometimes do call it as the well of hell, because if it bleeds, and it's very hard to stop. And we should know that there is an angulation to achieve this 100% removal of the TME, or the total mesorectal excision. There is this angulation. Beyond the steep pelvis, there's an upper angulation. And this part where you have to transect to get a better approach to mobilize the rectum. And I think from here, I would go to a patient I had where this patient has a malignancy 3 centimeters from the anal verge. So what we did for her is an intersphincteric resection. A lot of people would question the intersphincteric resection and the outcome. Well, for this specific patient, the surgery was done around 6 months ago, and in November we reversed the patient and she was continent. Usually these patients are incontinent to flatus. Other than that, they are fine. If they have loose diarrhea, then that also could lead to some incontinency. But with explaining all this and ensuring the presence and formation of a functional sphincter and not a perineal colostomy as sometimes named, the patients are happy with this outcome. So what we do is we go into the submucosal area over here, and then we enter into the intersphincteric space. Usually, it is nicer to go in between so either 5 o'clock or at 7 o'clock to enter into that space, and not at the 6 o'clock at the sacral area, because that is with a lot of adhesions. It's very hard to enter into that area. Knowing that any malignancy you remove with less than 1 centimeter margin, it's good to remove a frozen section and send it for pathology to ensure a negativity of the resection area. So after we prepare the perineal area and we identify, we take the biopsy and we enter into the abdomen, and we start by scoring the peritoneal reflection. This video is done from 2 patients, one with a upper, I think, sigmoid, and the continuation is by a rectal case. So as you can see, it's a bloodless field. We identify the inferior mesenteric artery and we remove it from its base. You can see the ureter is a bit elevated up, and there is a shiny glycerin layer over the ureter. That's the Toll's fascia. If you do not cut it, you do not cut the ureter. So you bring that down. As you can see, it's a bloodless field. You can appreciate the nerves present laterally on the video, which are the hypogastric nerves coming down from around the inferior mesenteric artery. Again, there's this lymph node which is at the apex, which is at the most proximal lymph node from the inferior mesenteric artery, and as you can see, that's the aorta under us. We prepare the fat, and we lift the lymph nodes. We bring the area of dissection. We identify it. I use Hemilox. Other surgeons just use one of the energy instruments. I feel safer. I love using a swab into the abdomen. It gives me a better vision. So after that, we prepare into the dissection. This is the so-called the tent, or under the tent view. The Arabic tent is usually in this appearance. And by this, you go into the splenic flexure. And I place the swab in that area, and then I continue from the splenic flexure downwards to do the resection. The proper mobilization is not enough of mobilization, so you really have to mobilize a lot of the transverse colon so it goes into the pelvis freely, especially when you're doing an intersphincteric resection, because that colon has to reach way outside the pelvis. So after we mobilize and we transect, after we mobilize the transverse colon, and it's usually at the level of the DJ junction. This is a female, so what we do is we just suspend the uterus up so it can give us a better vision into the pelvis with a suture. So all surgeries are done as a checklist surgery, so all surgeries are done in the same manner, in the same steps, in the same pathway. As you can see, the energy device has changed, and this is a different patient. We go into the pelvis, and as it's seen, it is a bloodless field. We dissect, we mobilize, and then we retract to go into the pelvis. At one point, I think I have nicked the rectum, which was rectified and corrected on the left of the patient. And after we mobilize the rectum all the way down posteriorly, we go anterior, which makes it easier to connect the anterior and the lateral wall of the rectum. We continue from the perineal part, and we extract the specimen. See on the left side, you can see that the meso over there, the mesorectum, has been a bit nicked, and which will be rectified soon. Here, this was the neck. Yes. So then we continue from the perineal area, and then we start minor mobilization, which is left. Over here we're transecting the part of the muscle of the sphincter under direct vision. And then after we do that, we reconstruct the remaining part of the sphincter. We exteriorize the colon, identify the clip which we have placed with the inferior mesenteric artery, identify the area of transection, and we form the anastomosis. The anastomosis is the colon to the anoderm, and we do not do a pouch formation because it did not show on the long term any superiority. So and the sutures which are placed, they are first the marginal sutures which are placed at 4 levels at 12 o'clock, 6 o'clock, 3, and at 9. These sutures incorporate with it the full thickness of the muscle, and then the rest are the colon to the anoderm. So after we do the control, and we do the transection, we suture the rectum to the wall. Before doing that, before doing the reconstruction, as we were checking for bleeding, we're controlling the muscle and suturing it. After placing the rectum back into the pelvis, and after we do the correction and repair, we bring the colon out and we do the anastomosis. In short, so anyway, I just want to show you the end product if we have a picture of it after we're done. We place a chest tube into the rectum. We keep it there for 48 hours. After that, the chest tube is removed. We protect the patient with a protective ileostomy, because after surgery, this is usually incontinent. We send the patient for physiotherapy, and we do pelvic practice and pelvic training. As I said, this patient was reversed on November, and she's very happy. Sentence, she told me, "I love you more than I love my husband." I think the reason is that she stayed with a sphincter. She went all over looking for this procedure. And I think by this I would like to conclude, and thank you very much.
Dr. Salhat, excellent, beautiful video. I knew someone with such a hairstyle like yours, you'll have a good video to show. Thank you very much. My question for you is, I saw you had a wonderful mobilization, and the colon came all the way down. Do you find dividing the IMV at a higher level gives you a better mobilization?
Usually when it's not the IMV which only helps, and yes, it does. It's not only the IMV which helps in a better mobilization. But after we do the IMV transection, we do a lateral mobilization of the flexure. So we go laterally in a horizontal fashion, and this gives us an opening, which would buy us around 2 to 3 centimeters more. So it's not only the higher always we transect the IMV at the lower margin of the pancreas. So that's always done there, but in addition to that, we do a horizontal mobilization just under the arcus rheonalde. And then that would give us a 2-3 centimeters leeway of mobilization as well.
Any questions from the audience? Just one question, Dr. Haytham. You told about the lymph nodes and the hemorrhage. What about the nerves, especially the post-operative sexual functions?
Yes, most of the studies, they did not have a unified a questionnaire for patients about sexual function. So they did not question ladies whether the vagina was dry or wet on sexual activity. So these questions were not done. And the only study which did that was the Taiwan study, where they went into details into the sexual functionality. And reality is, with the expertise increasing, the sparing of the nerves was possible. Knowing that lower you go, the higher risk of injuring the nerves again. So when you have in the lower 1/3, when you have a malignancy in that area, then the risk of injuring the nerve is even higher.
Thank you.